All a very warm thank you for attending this session early in the morning on a Sunday. And let's go quickly into the topic. So as you all know, childhood uveitis is not a very common disease, but you have an incidence of 3 in 1 lakh in 0 to 4 years and about 6 in 1 lakh in 10 to 14 years. But it is the most difficult to treat, and it can have blinding complications. The commonest types of uveitis by age: in the early years, it is the JIA, chronic anterior uveitis. In the later years, it is idiopathic chronic anterior uveitis and intermediate uveitis. And in an older age group, it is usually a B27 associated acute anterior uveitis. We follow the same classification for pediatric uveitis that we do for adults, and the features of anterior uveitis, intermediate uveitis, and posterior uveitis remain quite the same, like the keratic precipitates, which may be granulomatous or non-granulomatous, festooned pupil, the posterior subcapsular cataract, pigments on the anterior lens capsule, a specific thing that we see in pediatric uveitis, which is the band-shaped keratopathy. Causes, just like in adults, can be myriad. It can be a lot of causes which may be infectious or non-infectious, and each of these anterior, intermediate, and posterior have a long list of causes. Let us go one by one into the pearls that we can gather from here. In case number 1, an 8-year-old boy presented with decreased vision in right eye for 2 months with no redness, pain, fever, joint pains, or any other systemic symptoms. 2/60 vision in the affected eye, early band-shaped keratopathy, festooned pupil, but mature cataract. So there was no view into the vitreous. And the B scan showed a few coarse vitreous echoes, no RD or tumor or choroidal thickening, and was referred to the immunologist to rule out JIA, but there was no evidence seen. Basic infective workup was also negative, so we took up for cataract surgery after giving some basic immunosuppression. Underwent cataract surgery with IOL implantation, but found to have a large granuloma-like lesion in the periphery. So this patient had a toxocara granuloma, which was then later confirmed in histopathology because the patient developed an RD, and we went in and settled the RD. So pearl number 1 is, whenever you think of pediatric uveitis, we tend to think of anterior uveitis. But pediatric uveitis can involve the posterior segment, so always do a dilated examination in a pediatric child before you label the patient as an anterior uveitis. And especially in children, you may require to do an examination under anesthesia. That is something that we cannot avoid. So before you start and before you label the patient, before you send for investigation, see that you do a dilated fundus examination, if needed under sedation or anesthesia. The second one, Mudit had put this right at the last of his slides when it came to adult patients, but when you're dealing with pediatric uveitis, I would put it right in front, because this is something that if we miss, nobody is going to find it. So we have to absolutely not miss this. A lot of conditions can masquerade as uveitis. In children, we should remember about retinoblastoma and juvenile xanthogranuloma, and sometimes the leukemias. And as you can see from the pictures, they can very much look like uveitis, both anterior and posterior. So have a high index of suspicion for masquerades, and be sure that you're dealing with uveitis itself before you refer the patient to a pediatrician or a rheumatologist. Next, we go on to the most common systemic association of pediatric uveitis, which is juvenile idiopathic arthritis. It is asymptomatic disease, and it is detected on screening and sometimes accidentally, and it can be a presenting finding in juvenile idiopathic arthritis, because a little bit of joint pains in children are always dismissed as growing pains, or the mother says it will go off after some time, take some rest, give some maybe paracetamol syrup. So you may be the first person to actually diagnose this condition. And you know that they all present with this very typical band-shaped keratopathy and cataract with multiple posterior synechiae. Many of them develop secondary glaucoma. Sometimes, as a posterior segment complication, you can have macular edema and later amblyopia, and in the last stages of the disease, severe hypotony as well. So in JIA, points to remember are, it is usually anterior, very rarely panuveitis. It is usually a white eye with chronic course. Systemic JIA diagnosis is not a blood test. It is criteria based, so you will need your help from a pediatrician or a rheumatologist for diagnosis. Methotrexate and oral corticosteroids are the first line, and you may add MMF later, and in adalimumab in refractory cases. This was how we used to deal with it earlier, but now more and more we are shifting to first line adalimumab because it has excellent results in pediatric JIA uveitis. Topical medications have only an adjunctive role, and slow tapering of topical steroid with constant monitoring for the eye activity and IOP is absolutely essential. We all know the risk factors: females, oligoarticular arthritis, young age, ANA positivity, RF negative. So in a high risk JIA, you need a 4-monthly screening, and in a low risk JIA, 6-monthly. So my pearl number 3 for you is that topicals are not the mainstay of treatment for JIA uveitis. So if you have a child who has an asymptomatic anterior uveitis with sequelae, you have no business starting the patient on topicals alone without sending the patient to a pediatrician or a rheumatologist for evaluation and, if needed, systemic immunosuppression. And pearl number 4 is that all JIA patients should be evaluated with a slit lamp examination. And if the patient has been sent to you for screening, you cannot send the child back without doing a slit lamp examination for the child. Juvenile spondyloarthropathies make up 15% of pediatric uveitis and include juvenile ankylosing spondylitis, Reiter's, psoriatic ulcerative colitis, and Crohn's disease. Most of these are acute and symptomatic anterior uveitis and often with a hypopion. And unlike the other, there are some other points to remember. Unlike the JIA, boys are commonly affected more than 8 years of age. It is an acute recurrent uveitis that is bilateral and asymmetric. Many are positive HLA-B27, and they present with sometimes hypopion. IBD, as you know, Crohn's and ulcerative colitis come under this category. So not all pediatric uveitis are asymptomatic, and when you have a symptomatic presentation, it is probably not JIA. You cannot say hard and fast, but probably not. Now this baby, 10-month-old female baby, presented with abdominal distension, recurrent loose stools, progressive skin lesions, and failure to gain weight, had a lot of systemic findings: edema, depigmented hair, hypopigmented scaly lesions, and the eye had bilateral anterior uveitis with festooned pupil and cataract at 10 months of age. And investigations showed systemic granulomatous inflammation, and was diagnosed to have infantile sarcoidosis and started on systemic immunosuppression. Furthermore, underwent cataract surgery, is under follow-up. So infantile sarcoidosis, the points to remember are: it is an early onset disease. It can occur in approximately half of the cases. You will need liver biopsy, and it presents in the first year of life with a characteristic triad of uveitis, rash, and arthritis. And it is what you should keep in mind if a very early onset uveitis comes to your clinic. And the differential diagnosis is a condition called the Blau syndrome, which is juvenile, systemic granulomatosis, which is familial, and you have the NOD2 mutation positivity. So very early onset severe uveitis with sequelae, think of infantile sarcoid or Blau syndrome. Behçet's uveitis. Now pediatric Behçet's is onset of uveitis at 16 years of age or younger, and you may think it is very uncommon, but it is not. And we can get pediatric Behçet commonly in our population. The mean age is late childhood, male preponderance, bilateral involvement, recurrent panuveitis with retinal vasculitis and HLA-B51 positive. Pearl number 7, 1, it is more common than we think, and 2, it is a clinical diagnosis, and the HLA-B51 has only a very supporting role, which is something we must keep in mind. Now, going on to management of pediatric non-infectious uveitis, you will all agree with me, all pediatric non-infectious uveitis has to be investigated, rule out masquerade, assess activity and sequelae, and take a pediatrician or a pediatric rheumatology help. So topical steroids are initially used, but you have to hit hard, hit early, but they should not be the mainstay. Children can have a very high incidence of steroid-induced hypertension, so we have to keep our eyes open for that and try and taper and stop the topicals as early as possible. Now, sequelae, cataract surgery has to be done. You can use posterior chamber intraocular in the bag implantation, but always, always remember, ensure an activity-free period of ideally 6 months before you take up for cataract surgery, steady systemic immunosuppression, and give steroid cover at least 2 weeks prior and continue for a month after. Slow taper of both systemic and topical. Do not taper like you taper for your adult patients, and you may need to continue maintenance topicals for even more than 6 months. Remember to use more caution. If the patient is hypotonous, then you must try and reduce the hypotony. Use a stronger steroid like difluprednate to bring the IOP up a bit, control the inflammation well before you take up, or you will end up with a thumbsical eye. Uncontrolled inflammation with vitritis or retinal involvement, it is better to leave it alone without placing the intraocular lens. Leave them aphakic with a lensectomy and a vitrectomy. And never ever operate pediatric cataracts without adequate immunosuppression. BSK is much easier to treat. EDTA or phototherapeutic keratectomy can be done, but it keeps coming back if your inflammation is not controlled. Cystoid macular edema, like in adult patients, we treat with either posterior subtenon or a dexamethasone implant if it is not going away with just control of the inflammation. Secondary glaucoma, we have a long talk on glaucoma following in the next session, so I will not go into that, but you can treat with topicals. If it is refractory to topicals, then you can take up for mitomycin C trabeculectomy, or mostly they require valve surgeries. The last case, 12-year-old girl, bilateral pan-uveitis with vitreous haze, complicated cataract, and BSK. Vision is hand movements in the right eye and 6/60 in the left eye with hypotony, ciliary shutdown, and this is how she presented to us. After control of immunosuppression, she underwent cataract surgery with vitrectomy and oil and is maintaining a vision of 6/12. So finally, you may not be able to treat all of these cases with just anterior segment surgeries. You may need vitrectomy, sometimes for diagnosis, sometimes therapeutic. And with small gauge vitrectomy, now we have very less morbidity in children, and you can take up these children for surgery without much difficulty. So in conclusion, pediatric uveitis is like an obstacle course. The road is long and arduous. Hurdles and unexpected twists and turns are there because it's a long journey that we have with our patients. But finally, it is rewarding when they are happy and they can draw and see the world. And this is a small thing that I have started in the world of pediatric uveitis. It is called Childhood Uveitis Blindness Trust. Because of these children require a lot of financial support since they have a long-term treatment that is required. We inaugurated it in the annual CME called Ignite at Kochi, and it's doing well. I will be happy to share the details with anyone who would like to help us in the way of contributions. Thank you all for a patient hearing, and thank you to Namrata ma'am and AIOS for giving us this opportunity.
Yeah, thank you, Dr. Natasha, for wonderful talk. I just wish to ask you and same to Dr. Mudit sir in reference to adult patients. Nowadays, with the availability of quantiferon TB Gold test, and like previously also we used to do Montox, sometimes it becomes difficult to decide when to suggest pulmonologist to start on ATT. So if a patient is having like not very clear picture in favor of ocular tuberculosis, but yes, anterior segment or posterior segment inflammation is there. And if quantiferon TB Gold test positive, Montox positive, chest X-ray not in favor of pulmonary TB, then how you decide on to start with ATT?
So the first thing is you do not treat a test, you treat a patient. You treat it in conjunction with your clinical science. What does a MONTO tell you? It just tells you that at some point of time or life, you have been exposed to the TB antigen and your body has developed antibodies against it. That's what MONTO tests. The same principle nearly holds true for quantiferon. So you are not treating your patients on the basis of your MONTO or your quantiferon. You treat them in conjunction with the symptoms that you are having. So if your patient has got clear-cut signs or patterns of a subpyginas like choroiditis, your life is easy. If you have got vasculitis with subvascular CRA patches, again you know probably you are dealing with ocular tuberculosis. If you're just isolated seeing intermediate uveitis or just a vitritis, that is where the dilemma starts. I would probably not treat them just on the basis of a positive MON2. Get a CCT chest done, not a chest X-ray. Lot of times people get an X-ray done which usually does not pick that much details. If you can possibly get it done, get a contrast enhanced CT. That will also help you in looking at what is happening over there. So if all of those signs are possibly corroborating, you may still start them on ATT, but not otherwise.
Sir, if CCT negative and only anterior segment or only vitritis,
I
then
do not treat my patients with vitritis with an ATT to start with, just because their MON2 has come positive.
You should have the features that have been told as typical of tuberculosis in the eye with a positive test if you want to start TB treatment. If you have not so typical features, you have generic uveitis, like you said, anterior intermediate uveitis, and you do not have any systemic evidence of TB, you do not need to start ATT. Yes.
okay. Thank you, sir. Thank you, ma'am. And thank you, Mudit sir, for wonderful talk. Thank you, sir.
How we investigate the cases of GIA?
We cannot investigate, sir. It is a clinical diagnosis with a lot of criteria. It is a criteria-based diagnosis. So what we usually do is the pediatrician or the rheumatologist will be able to guide us. There is no test that we can do to diagnose GIA.
Thank you, ma'am. Thank you, ma'am, for that wonderful talk. I have two questions. One is, in a case of pediatric uveitis, you told we have to start systemic immunosuppressants before taking up the patient for a cataract surgery. So do you take any specific, like an IV MP or something just before doing a cataract surgery and post-op?
No, no. IV methylprednisolone is not required. If the patient is on adequate immunosuppression and you have a disease-free interval of 6 months, which means there is no cells in the anterior chamber for 6 months, then you can take up the patient with a age-appropriate dose of systemic steroid. Usually our rheumatologist starts about 2 to 3 days prior to the cataract surgery and then takes the patient up for surgery.
There is no IVMP before
not
that.
required,
Okay.
unless you are taking up the patient when the patient is having like severe inflammation for whatever reason. Sometimes you are not sure of the diagnosis or very hypotonous eye and you want to take up, then they may recommend IVMP, but generally not.
Okay. Then the second one, in a case of pediatric JAIA, so till what age you will follow up if the patient is not having uveitis? Like,
Usually by 15 to 16 years, if they are not having uveitis, you can stop your follow-up.
okay, thank you.
Next. Okay. So if we have done